That's really what I'm trying to do here. So that's why the fee schedule, to me, I think it's the kingpin of the practice. It's the soul of the practice, I tell people. It's the soul of the practice. Because if you're collecting 30%, you don't have a very good soul. It's a foolish thing to do. It just upsets your patients. Why would you upset your patients like that? And these therapies that are so outrageously expensive now, it's crazy. It just doesn't make sense. So does everybody understand this, what I did here? And if you go home and you work with this and you have some problems with it, you get a hold of Mariana, she'll get a hold of me, we'll get on a conference call, and I'll walk you through it, okay? Because I could go over this for hours, and you could go back and say, now, what did he say about that one? Did this and this for it over here? Just follow the formula clock. Just the thing you're remembering, your fee schedule, you want it to be some kind of percent above Medicare. Benchmark it against one of your payers, like Blue Cross, United Healthcare. You can compare. Matter of fact, you can actually create a table and plug in your Blue Cross and calculate how they're paying you. Are they paying you 20% above Medicare, 10%, 30%? What are they doing? I can tell you in North Carolina, Blue Cross down there on the chemo pays 160% above Medicare. Okay, and Blue Cross of Georgia, or not Blue Cross of North Carolina. And the managers went down and negotiated that because they took the drugs to the ASP plus 6. They did that about 5 years ago. So there are practices out there getting this 160% above Medicare for the chemo codes in a trade-off to take less for the drugs. So if we go back to my argument of our business plan, that maybe we might say we'll take drugs at invoice, then what's going to be my chemo price? 100 what? I don't know. I got to do the calculation. But I'll bet you it's going to be somewhere about 180 to 200% above Medicare as a trade-off to give up the drug margin. Right? Why not? If that's their issue, that they're so dang on concerned about the drug, okay, fine. Pay me for my procedure, pay me for my level 5s, my E&M, appropriately, and I'll gladly give up the drug as a loss leader, but you got to give me something, some kind of a fee to cover my covering costs, and you got to pay me in 15 days or something, I don't even care. I'll set up some kind of a system. They can send the check off to Oncology Supply or to ION. Doesn't bother me. If it's a loss leader, who cares? Matter of fact, we could go back to the old CAP program. How many remembers that? When Medicare had that CAP program, I was one of the few guys that participated in that. I had a couple clients that did. It was a disaster that was. It was a good idea. They just had the wrong people running it. And basically, the CAP program was they had a vendor who would buy the drugs for Medicare. And so if you needed a drug, you called the vendor. And he was supposed to ship it to you, okay? And so the government paid the vendor. And the doctor was out of the picture and buying the drugs. The only problem is every time he called the vendor, he didn't have the drug in stock. So you had to go buy the drug from Oncology Supply or from McKesson, and then you had to replace it with him. So we had these debits and credits going back and forth all the time. It was ridiculous. So they just didn't set it up right. And so we went up in Washington and met with them and told them what they did wrong in that and said, look, go fix this problem, and I think we'll get doctors to buy into this. This is not a bad idea. But you got to take care of my visit. You got to take care of my chemo problem. See, that was one thing they didn't want to do. They didn't want to fix that problem. So, all right, enough for the fee schedule. How are we doing for time? 11:42. Wow. Okay. Let's get back here on track here. Okay, education about how hospitals are paid and how this can be used to contract. Oh, I wanted to show you this. Let's see if this works again. Okay, here's an article. I'm going to go in here. Key up this here article. This is Charlotte, North Carolina, where the major newspaper came out and said, nonprofit hospitals thrive on profits. Hospitals in the Charlotte region are among the most profitable in the U.S. They have billions of investment in real estate. Experts say they should do more to lower patients' rising costs. Okay, there's the main entrance. They had this big article in there, and they had this big shot here. You got his picture. But you go down, you kind of read this article, and in there they talk about the charge master. Let's see if I can find that. Nonprofit, and by the way, this is a nonprofit hospital. That's kept secret in the world. Okay? Region are respected community institutions. They save lives, heal the sick, and provide good jobs. And at the same time, most of them are stockpiling a fortune. It's a great article. So the point is, I'm trying to say, the market is already responding to these hospitals who are overcharging. Don't you get caught in the same trap. You've already been accused by this one and other people. That's why the charge master makes sense. But the other opportunity is, if we can get data and get information, I think we can go negotiate with United Healthcare especially, because Lee Newcomer, how many know him? He's the medical director of United Healthcare, medical oncologist. He's, up until last year, he was always bad-mouthing us in private practice until all the practices on the East Coast became hospital-based. He all of a sudden starts saying, you know, the private oncology practices look pretty good. See, he's had a wake-up call. So the point is United Healthcare might be our first targeted insurance company to go talk to. How many of you guys have a lot of United Healthcare here? Do you have a lot? Some don't. That's the problem here in LA. You guys are scattered all over the place. Yeah. So, I mean, but, you know, that would be a place to start, because once you win there, you can benchmark to the next one, the next one, the next one. Now, you guys still have a lot of the IPAs out here, right? Yeah. I'd like to learn more about why they continue to thrive and are ripping you guys off. Well, I mean, I think we need to have a serious discussion. But before we do that, we need to get some fee schedule information and allowable information and see what the benchmark is and see where we're at. I got to get a baseline here, guys. You guys got to help me out here. I need data. Okay. All right. Well, I need that, but I need it from a lot of you, because you need to see, is the IPA similar, or are they all over the place, right? But I think they're controlled by 2 or 3 companies. You don't know that. I'm not sure. Well, that's because they're getting away with it, because they know they can get away with it. Right. See, and we need to go after that. And that is a tragedy that they're getting away with that. That really is a tragedy. So that's something. But I just wanted to see that Charlotte. So if you wanted to actually do that when you get home, if you wanted to look it up, you could actually see that or show it to the doctors. And the point I'm trying to say here, we know hospitals are overcharging, so that's our opportunity to influence the market to pay us appropriately, because that's what we're all about. Time to document, audit the physician, and extend their clinical documentation. I'm going to go over some baseline things here. It looks like we got about, 15 minutes. And then we're going to do the audits this afternoon here. How many of you actually have audited physician notes? Many of you? 1, 2. Oh, wow. This is going to be fun this afternoon. This is going to be real fun. This is our first effort to bring you some notes that you're going to sit down and try to do some audits. But one of the things I want to make sure, and you guys who've done some audits, you can appreciate what I'm going to say here. The first thing you need to understand about documenting a physician note, in 1988, this guy here, Dr. Hazio, he was the one who created the RVU system. He said this in his report to the healthcare authorities who were struggling with defining the methodology to assign value to payment for services. He said physicians have 4 major dimensions: time, mental effort and judgment, technical skill, and physical effort and psychological stress. There's one slide you show your doctors, you show them this. And then you ask them, why aren't you billing lots of level 5s? Okay, because you stop and think about it. It's not so much the time. The mental effort and judgment on taking care of a chronically ill cancer patient is horrific. The technical skill associated with taking care of that chronically ill patient is horrific. And the physical effort and psychological stress is unbelievable. That's one thing I'll give her credit in her book here. She did say that oncology is one of the hardest medical specialties in America. And she said these poor doctors are dealing with death and dying patients every day after day. But then she said they're overpaid. It's a great book to read. It's a wake-up call. It was a real wake-up call to me to read that book. I'm still reading through it. But the point this is so important slide because it is the core, it's the soul of what the oncologist's effort is, why they should be paid and why they should be doing more level 5s. Even if their note somewhat is robotic. Okay. Even if their note is, because each note stands on its own. It's in there, the regulation. And I won a big audit up in North Dakota 4 years ago where a doctor had 60 notes. They tried to downcode all of his notes except the first one and the last one. 10 patients, or 8 patients, I can't remember, a certain number of patients. But we went back and we made them change it all, and he got everyone paid at level 5s. And he was doing, and by the way, he was doing 90% level 5s. And every one of his notes were robotic. But it was easy because he had breast cancer patient, lung cancer patient, prostate cancer patient. He had them on treatment. He was giving their treatments week after week, and he was doing the review, doing the exam. Patient was stable, getting chemotherapy. If you know anything about coding, the coding basically says that the patient's stable, that's a level 3 risk. But if you're giving chemotherapy, that makes it a 5 risk because the risk of the chemo is higher than the stable. Does that make sense? So they're saying, we're going to give you credit for your risk factor of your technical skill, your mental effort and judgment, and your psychological stress, and reward you because you're keeping the patient stable. What a novel approach. 1995 guidelines. But now, what are the auditors doing today? They're trying to say, in order to build level 5, you've got to have 3 or more problems, and the patient's got to have a problem going worse or a new problem. That is not what the 95 guidelines say. So they have taken our documentation, they've taken the guidelines, and they've changed the wording around to fit their needs. That basically tries to say now, if you got the robotic note, and the patient's stable and they're getting chemotherapy, you can't bill a level 5. What? Where did you got? You know what? I'm sorry. I'm looking at the same book you're looking at, and you told me that you follow the 95 guidelines. That's what the 95 guidelines saying. You're not following. What? This doesn't make sense. So, and we're going to go over that this afternoon. When you see this audit form, and you see what they've done to it, you're going to just go, "Oh my God!" And then you're going to see that's the challenge. But that's okay. It's the opportunity too. But I just wanted, this is a very important slide to show your doctors. Slide number 19. So you make sure you go over that with your manager that when you get back home. Because a lot of them don't realize this, okay? Okay, how to create a meaningful physician note that becomes a perfect level 5 service. You got the staging, toxicity scores, HPI symptoms gathered, scans reviewed and ordered. Oh, how many times? You guys pre-cert the PET scans? How many times when you go to pre-cert, there's nothing in the chart? Surprise, surprise, surprise. Why am I not surprised? Yes. Well, I understand. You know what? It's okay. We're going to take what? We're just going to take one step at a time. We're going to get there. Okay? We're going to get there. Actually, the latest I start arguing says, if you don't want us to bother you anymore, just put it into the Y, or I'll give you a form, whatever. Okay? Changes treatment plan therapy, oral pharmacy review, changes note high complexity drugs identified. By the way, there's a lot of high oral drugs out there. I mean, there's some really pretty wild stuff out there. I have no idea what this stuff is. All of a sudden you start finding this out, you start talking to the pharmacist, they start rattling off these names and like, oh my gosh. And the reason I know it's so complex because you can't get it authorized. Or you can't get it pre-certed. Because they don't want it because it's so expensive. It's $5,000, $15,000. Well, you know, I'm sorry. If we're ordering a $5,000 drug, that sure is not a minor complex issue. But somehow I got to figure out how to identify that. Okay? Lines of therapy, of course. End of life discussion. Specialty lab. This is a big one here. I'm going to show some slides up here. By the way, GenPath, you guys have these labs come in. You know, they're doing these. Okay? It's amazing. You know, the drugs used to be the kingpins that bring lunches in. Now it's labs. It's pretty wild, ain't it? and some of them want you to buy equipment. Some of them want you to do this. They want you to wholesale the lab. Oh, my God. It's like, it's like, go away, leave me alone. But one thing I did on these specialty labs, the reason we do GenPath is because it's just cut and dry, simple. Here's what we offer, blah, blah, blah. But what's more important is I'm trying to work with them that if our doctors order that lab, I'll show you some things here, I'd like to get a report back. When I get a report back, that it drops into my EMR as part of my note. In such a way that it's the physician's, what he's saying to the patient based on what the pathologist said to him, that adds meaningful information to his note that makes his note more complex. Does that make sense? In other words, if he's ordering this special test that costs $5,000, then that's one complexity. Then, because he's trying to find out a certain thing, right? Now, if he comes back with the report and he has to interpret that report, that's another complexity. So I've got two high complexity issues going on, ordering and also interpreting. Yes?
Then it's not face-to-face.
Pardon?
When you get the result back, you're not in front of the patient.
Well, you really should be bringing them back. Right. You should really bring them back and do an evaluation. But then that's when it should be part of that note. I'm just saying, that's the cool stuff I'd like to see happen. And I don't care if it's GenPath or Genoptics or whatever. They should be working with us. So if we order these tests and we get these results back, then sometime later we should be able to get the data back that says, gee, last year we ordered 5,000 tests from GenPath, and out of the 5,000 patients, we treated 5,000 patients this way, and out of the 5,000 patients, 4,000 worked. And the other 1,000, something else happened that was good. That's great. That's outcome, right? But you know what? I order it, test result comes in, it's over. There's nothing else. I don't even know if they changed the regimen to fit what they recommended, and what was the outcome of that 6 months, 4 months, 3 months later. I have no idea because I don't have any data. Because I'm not tracking the data. I'm not looking at the data. So I'm trying to challenge these lab companies and say, if you want to do something for us, help us get data. Help us get the data. Because you're the depository of the data going in as the order and the report coming back, that maybe you could be the trigger that helps us to ask key questions in a survey or something that can get the output data 2 months, 3 months later down the road that tells us something about what we did and how we helped the patient and quantify it. God, that would be great if we could do that. That's how I'm thinking. Okay. So, of course, why is the physician ordering scans, and how did the scan help the physician with the care? Boy, it'd be nice if they would say something like that, wouldn't it? Yeah. See, if I could take that review of system and exam crap away from them, you'll have more time to do this. Pardon? Well, I know, but here's the obstacle you're going to have to overcome with an oncologist. Do we have any doctors here, by the way? I feel like I'm beating up on. Oh, one. The problem with the oncologists is they feel everybody should know everything that they're doing. And they feel that when somebody looks at their note, they should be an oncologist and should understand the note of what he's trying to do. So if he says PET scan ordered for breast cancer, he shouldn't have to say, and I'm ordering this because I'm restaging the patient. Am I right, doctor? But unfortunately, doctor, what we're dealing with is these peoples, I used to use the word moron, but I thought I should be kinder, on the other end, who are interpreting my notes, reading the notes, don't see that. And so they use that against us. And so that's what I've got to figure out a way is to get you away from doing the redundant things and get you to give us more meaningful data and more information that's more valuable, that when anybody looks at that note, they can interpret it from an 8th grade level, what you did. I hate to say that, but that's what I'm up against. That's what I'm up against. I had a nurse just last week. She hung up on me. She was an auditor. She's telling the doctor, well, I could see you did this very complex hematology visit, but you didn't document the 4 HPI elements. I'm like, he doesn't have to document the 4 HPI. If he has everything else there, he's got 99% of the note there. You're supposed to upcode him and give him the credit. I don't have to. No, he didn't give me the 4 HPI elements. So she took him down to a level 3 on this very highly complex hematology patient. It's unbelievable. But that's what I'm up against. So what are we doing? You'll find out later. I'll tell you how I'm actually filing complaints. I'm trying to get her out of the circle. I don't want her as an auditor. Okay. This is interesting. A lot of people didn't know this. This is the best kept secret. This is the Medicare final rule on physician time file. And how many of you heard that a level 3 visit is supposed to be 15 minutes, a level 4, 25, and a level 5? Ever heard that? Right. Did you know anything about the pre-service, post-operative, intra-service times? Did you hear about these other times? So when a doctor says, I spend 20 minutes with the patient doctor, you really spent 25 minutes, okay, or you might have even spent another 35 if you had some kind of a procedure or chemotherapy issue going on. I don't know why they use a post-operative, but that really is what they call more time spent after the fact, meaning you make phone calls to referring doctors, you talk to other people, and they give you points for that, by the way. If you say, I'm going to talk to a referring doctor, or if down at the bottom of the note it says CC Dr. A, Dr. B, and Dr. C, you get points for that. Okay? Oh, yeah. You only get 1 point, but it should be 4, but you get 1 point. So that means they recognize that the physician is communicating with other doctors, and he gets points in his note. But this, I thought, when I pulled this down off of the Federal Register, I thought, oh my God, there's what I've been looking for. Because people always argue, especially certified coders will say, you can't go over the 15 minutes of level 3, and that's it. I say, well, I know, but they give you 3 minutes pre, and they give you 5 minutes post. 23 minutes. So really, that 23 minutes, if you want to be technical, is a level 4. See what they've done? Just an interesting way of how they've done that. So see, I'm trying to figure out how to use that. Because typically what happened, a level 5 for a medical oncologist typically would be about a 15-minute visit. 15 to 20-minute visit tops. Level 5. Level 4 would most probably be about 10, 15 minutes. Level 3 is going to be somewhere in the 10-minute range. So it's out of whack with the time element. And remember, time is only there for counseling. That's it. Counseling. Nothing else. Okay? You could have 6 level 5s in 1 hour. Based on complexity, not based on time. So if Mrs. Smith comes in day 1 and doctor does a level 5 visit based upon review, exam, decision-making, says we're going to give you chemotherapy, and she says, okay, I'll come back tomorrow. I want to go home and talk to my husband. Okay, and he spent 15 minutes with her, and he did a level 5 because he wrote out the plan, did everything. Next day, she comes in the door, and her husband's with him. They go back in the room there. He spends 40 minutes with that patient. What do I got? I got another level 5, don't I? Because he spent 40 minutes face-to-face with that patient, or if he spent 25 minutes, but then he documents, he gets to add some pre-time, post-time on the back there that gets him up to that 40 minutes. So I tell doctors, when you're documenting, don't say I spent 15 minutes face-to-face. I spend 40 minutes taking care of this patient. I spend 60 minutes taking care of this patient. What does that mean?